Hello, my name is Kayla St Amour. I'm a nurse practitioner and I am presenting my DNP project on the implementation of depression screening in aesthetic practice. My chair was Dr. Gordon West, the second reader, Dr. Marilyn Riley, and my community member was Taylor Miller, BSN, RN. The background of this project was that depression is a very prevalent and debilitating mental health condition. Depression continues to be underdiagnosed and undertreated, and patients who seek cosmetic treatments may experience underlying emotional distress or body image concerns that go unnoticed. By integrating the PHQ-9 depression screening into routine care, we can help bridge the gap between aesthetic medicine and mental health, which is so important. Depression significantly impacts quality of life, creates exacerbations in chronic diseases, and claims many lives annually. We often unrecognize depression, especially in aesthetic and outpatient settings that are not as traditional as something like primary care. Statistics show that approximately 21 million adults, or 8.4% of the US population as adults, experience at least one major episode of depression in the past year. That is according to the National Institute of Mental Health. Also, according to the American Psychiatric Association, as of 2023, the annual economic cost of major depressive disorder in the United States was estimated to be around $326 billion, which includes the direct and indirect costs that depression creates. The importance of this project is to emphasize the nurse's role in early detection, assessment, and ethical practice surrounding mental health in all areas of healthcare. The purpose is to evaluate the effectiveness of implementing a standardized PHQ-9 depression screening protocol during aesthetic procedures. We ensure patients receive referrals and resources, and we contribute to overall patient well-being. The significance of the project includes the project aim, which was to improve depression screening in the med spa setting. We do this through implementing the PHQ-9 screening tool during routine aesthetic appointments. The objective was to increase the identification of previously undiagnosed or untreated depression. We can promote early intervention and provide appropriate mental health referrals for these individuals. This, therefore, enhances holistic care and ethical patient care by addressing both mental health and physical well-being. The clinical question for this DNP project was, what is the prevalence of depression among patients undergoing cosmetic neurotoxin treatments in a med spa setting? How does implementing the PHQ-9 depression screening impact the identification and management of depressive symptoms in these patients? As just mentioned, the clinical question is restated here. What is the prevalence of depression among patients undergoing cosmetic neurotoxin treatments in a med spa setting? How does implementing PHQ-9 depression screening impact the identification and management of depressive symptoms in these patients? There's not a ton of literature directly surrounding aesthetic practice and depression screening. It is a very up-and-coming field, and it is something that needs to be further researched. So, in reviewing the literature, the overview shows that depression is a major health concern when it is undiagnosed or untreated. The PHQ-9 depression screening has been proven as a valid tool. Literature does support that using depression screening can help with diagnosis and treatment and promote positive outcomes. Research shows common findings across studies with minor differences and weaknesses. The strengths of the literature that I reviewed show that there are large sample sizes which enhance reliability. Most studies included greater than 550 participants, and the largest one included 52,944. Most of the literature was all ethically sound. It had IRB approval, law adherence, and disclosures transparency. All patients were adults and they were 18 and above. There were self-report of PHQ-9s, which minimized observer bias. It was culturally adaptable with accurate translations in multiple languages. And a strong validity and reliability was shown with the PHQ-9 and supported by internal consistency scores. There were trained clinical staff which increased the accuracy and detailed demographics which enhanced specificity. The weakness of the literature included predominantly cross-sectional designs which limit long-term insights. There was only one randomized controlled trial that was identified. There was no longitudinal data. Some interview-administered PHQ-9 studies could show a potential bias, and studies often were conducted in a single setting, which limits your generalizability. Vague exclusion criteria could reduce the study precision. Some gaps found in the literature include that there was a lack of routine depression screening, underscoring that there is a need to screen across multiple populations because there were not quite as many as I would have liked to have seen. There was limited follow-up after a positive score. So you get a positive score. What do we do with that? That is something that needs to be further explored. Few studies report referral completion or ongoing care after screening. So again, they're scoring. Yes, you have a positive score, or maybe we found some depression, and now where do we leave this patient? It's very important to continue the chain after that. The data on the effectiveness of screening interventions and quality of life is scarce in terms of long-term results after they are screened. When you have found, the positive screen, what do we do with that again? Limitations. Very few studies directly connect aesthetic medicine and mental health. The field of aesthetic medicine, as mentioned, is emerging. There is limited research available. Existing studies, therefore, require inferences from related fields. So the mental health PHQ-9 in something like primary care. So there's a lot of research that shows that the PHQ-9 being implemented is very helpful in determining if someone may have depression and what steps are going to be taken from there. However, there is not a lot that links it to these non-traditional practice settings like aesthetics, where it may be so important as you're being cosmetically altered to first, check the underlying problems here. That being said, there is a need for longitudinal and specialty-specific research to establish a stronger evidence base in areas such as aesthetic medicine. The theoretical framework that was utilized is Lewin's change theory. This served as the guiding framework for this project, and it uses a three-step project of unfreezing, moving, and refreezing. This provided a structured approach for planning, implementing, and sustaining change. In the project formation, the impact was great. Unfreezing, we identified a gap that there was no existing depression screening in aesthetic medicine. Moving showed that we implemented the PHQ-9 screening, educated staff, and integrated the process, such as the PHQ-9 in the EMR, into the workflow. Refreezing, we established a sustainable clinic protocol to continue with ongoing depression screening in the aesthetic practice. This ensured the project was evidence-based, organized, and sustainable from start to finish. Design. This project used a descriptive, quantitative, quality improvement design. The purpose was to integrate systematic depression screening using the PHQ-9 depression screening tool into the care of patients receiving Botox treatments at a med spa. Although there are a lot of treatments that are done, we shrunk it down to just neurotoxin injection treatments. Prior to the project, no depression screening protocol existed within aesthetic practice. The project setting and participants. Conducted at a med spa in northeastern United States, we included patients aged 18 to 65 receiving neurotoxin Botox treatments, and the med spa owner approved implementation. No recruitment or incentives were required for this project. The data collection process consisted of patients electronically completing the PHQ-9 depression screening tool via a HIPAA-compliant EMR system. Positive screens were moderate or severe, triggered a referral to mental health services and follow-up appointments. Data was extracted from the EMR, and only the minimum necessary de-identified information was recorded. Data was tracked on a structured data collection sheet used for analysis. The rationale for this design was that we were allowed objective measurement of depression prevalence using the descriptive quantitative design. The QI approach ensured focus on improving clinical practice and patient outcomes by establishing a new protocol. The methods provided real-world data to implement and evaluate the impact on PHQ-9 screening on the identification management of patients who may have not been diagnosed otherwise. This project helped answer the inquiry to show how standardized depression screening does help in early detection and supports holistic care in the aesthetic setting. The sample included a population of adult patients 18 to 65. They received Botox, neurotoxin treatments at the med spa. The study period was from July 15th to August 15th of 2025. Inclusion criteria included adults seeking Botox treatments during the period. There was no prior diagnosis of depression, and they were not taking any antidepressant or mood stabilizing medications at the time. Exclusion criteria was if you were outside the 18 to 65 range, or if you were a patient with known depression or unrelated medications as indicated by your health history. Sample size and characteristics. The study design was a qualitative descriptive analysis, and the target sample size was 100 Botox patients, which was based on the monthly average of about 60 patients. We were able to reach the target sample size even though it was a shorter study period. There were a sequential inclusion and exclusion that proceeded until 100 eligible patients were identified. The demographics showed that 65% were Caucasian and 35% were other ethnic groups, and we included all genders. The data was extracted from the EMR records of consenting patients. Informed consent was obtained prior to the screening. For the analysis of the data, we used a statistical analysis using a qualitative descriptive approach. Because there were no formal statistical tests or programs that were appropriate, no comparison group or hypothesis was being tested, we focused on data review and process evaluation with this project. The descriptive data review used information extracted from the EMRs, and we used a process evaluation to determine how effective what we had done was. Histograms and charts were used to visualize trends in PHQ-9 screening results, patterns and themes related to depression, and prevalence of referrals. The rationale for this approach was to evaluate a workflow process change, not to test a hypothesis. Qualitative data review allowed identification of trends and the impact of screening implementation within the setting. Process analysis helped predict future outcomes and guide sustainably using depression screening in aesthetic practice going forward. Our results were actually pretty interesting. I found that there were more patients who screened positive than I had initially thought. So out of the 100, 2 refused, so we actually screened 98 patients. So the percentages were quite interesting. So no depression was 45%, mild depression was 41%, moderate was 14%, and thankfully nobody 0% scored severe depression. But when you look at those numbers, it actually shows you that there were more patients who were depressed out of that screening group than who were not. So that was very impactful, and I felt really good about how the project went and how many patients were actually identified that could potentially have a much better outcome based off of the screening. So limitations included a limited screening population as we only used patients receiving Botox cosmetic treatments. There was a delay in project start. We were uncertain about the IRB approval, if it needed a full or not based off of what we were doing, so it took a little extra time to get to the study period. Although the project timeframe was only about a month long, the target of 100 patients was reached, so that was sufficient. We were unable to screen every patient, so Botox was the focus. Generalizability, findings were relevant, but they're not widely generalizable to other med spas or regions, so it would have been more helpful if we could go ahead and screen multiple facilities in different areas. The demographic profile showed 75% ended up being white females, and ethnicity 80% were white, 12% Hispanic, 4% Asian, and 4% Black or African American. So that was a little skewed as well based off what we thought there was a lot more prevalence of the white population. Socioeconomics across other med spas in different areas, again, may impact, as well as possibly different treatment offerings. So if we extended it to do maybe laser procedures or filler, things like that, then maybe we would have seen some different results. So this really only kind of applied to Botox, but it did bring into light the need for screening in non-traditional settings, especially aesthetics. So this is a very highly sustainable QI project. The PHQ-9 screening tool can be embedded permanently in the EMR system, and providers are able to review and address positive results in real time this way. In order to minimize the limitations, we maintained a supportive, confidential environment for our patients. We provided education to staff and patients in order to make this work. We emphasized that voluntary participation and privacy was crucial, so there was a reduced stigma. We integrated follow-up education, referrals, and resources and gave handouts to the patients, as well as encouraged their participation by emphasizing the value and benefits of screening. The effects of limitations on results are that the short implementation phase limited some data collection and screening only those Botox patients as well. We would benefit from an expanded time frame and population. Key results are that 14 patients were identified for moderate to severe depression, ended up being moderate, no severe. Therefore, they received mental health education with a handout with referrals to local mental health providers and follow-up at the med spa. Out of the 14 patients, 11 attended the med spa follow-up appointment. So I believe that that was a very good number that followed through with the what's next from here. 98 patients were screened. 54 had mild to moderate depressive symptoms, and 14 had moderate, requiring follow-up. Interpretation of findings were that there was a higher than expected prevalence of depressive symptoms in the med spa patients, as I previously stated. I felt that this was very impactful within the practice. Aesthetic patients may see cosmetic treatments as coping mechanisms. There was a lack of prior screening, and the PHQ-9 was then integrated into the EMR. In terms of patient care, this really helps to bridge the gap between aesthetic medicine and mental health services. We can identify early depressive symptoms. We can have improved collaboration between aesthetic providers, mental health providers, etc. And this enhances patient safety, holistic care, and overall well-being. For future implications, we must provide ongoing staff education, refine follow-up protocols for better continuity of care. We could do a longitudinal data collection to assess the sustained impact, and we can expand it to multiple med spa sites in various areas with different socioeconomic backgrounds to then see really what's the benefit overall. And of course, continue to use validated tools like the PHQ-9 screening tool that can be self-administered. This impact is big. It integrates mental health screening into routine aesthetic care. It promotes that holistic evidence-based practice, enhances provider awareness as well, so that we are treating the whole patient. Aesthetics seems to be a kind of forgotten area of medicine where it's glorified, especially in this day and age, and it's so important that we remember it is still healthcare and we are still treating patients, not just a wrinkle or a fine line. It is the whole picture here. This helps to impact patients in a positive way through early diagnosis or identification of undiagnosed or unrecognized or unthought of depression. Timely referrals to mental health resources are going to be important. This improves well-being, safety, and patient-centered care, which is really the heart of what we do. We reduce the risk of adverse mental health outcomes and putting band-aids on problems that maybe go deeper. This can bridge the gap between aesthetic medicine and behavioral health. It demonstrates value, and it provides a model for evidence-based, sustainable QI initiative. We encourage collaboration amongst providers, which should exist in all fields of medicine, especially aesthetics. Implementing the PHQ-9 depression screening in a med spa setting had successfully identified patients with depression that were not prior identified. 14 patients received mental health resources and referrals for follow-up care. 11 of them actually returned. This demonstrates a holistic, evidence-based nursing intervention that can be sustainable in aesthetic practice. This project improved early detection and prevention. It increased staff awareness and sensitivity towards emotional well-being, not just cosmetic appearance. This strengthened collaboration between the aesthetic practice for which this was conducted and the mental health providers within the area, and it highlighted the vital role of nurses as patient advocates for holistic well-being and to address the patient as a whole person. What would I do differently if I did this again? I would expand screening to all med spa patients, incorporate more staff training before implementation, and develop a formalized tracking system to then monitor what happens really after that 2-week follow-up. Future plans are to continue depression screening as a standardized practice in aesthetics, keeping that PHQ-9 integrated within the EMR. We'll provide annual education for staff on mental health awareness and reevaluate providers in the area as needed to change if people come or go. We will establish a referral partnership with local behavioral health providers. The impact of the DNP program for me really strengthened my ability to lead quality improvement initiatives using evidence-based practice. It enhanced my confidence in translating research into clinical application. I developed stronger leadership, critical thinking, and interprofessional collaboration skills. And I personally am now inspired to be a change agent in healthcare and policy development. It inspired me to promote mental health integration within all areas of healthcare. Truthfully, I graduated from Maryville in 2017 as a nurse practitioner and never thought I would go back for my DNP and certainly not get involved in policies. And this project really inspired me to do that, especially in aesthetic medicine where there is a lack of policy and regulation that I think truly needs to be enhanced for patient safety. This really drove that home for me, and I feel very empowered to be a change agent and be very involved in safety and healthcare and patient advocacy going forward. Thank you for attending my project. I hope you found it as interesting as I did and a very crucial need that has to have an area of greater research. So I'm very hopeful to see what the future brings for aesthetic medicine and all of the things that come with it as a true healthcare profession. My references are listed on the following slides. Feel free to review them. There's a lot of great research in there. Thank you again for attending. Have a great day.